All right, good afternoon, everyone. Welcome to the University of Michigan Sound Support's Parent Webinar Series. My name is David Clark. I'm the Sound Support Coordinator for the University of Michigan's Hearing Rehabilitation Center. As many of you are aware, Sound Support is an outreach grant funded by the University of Michigan Department of Otolaryngology and Michigan Medicaid. The grant is designed to provide outreach and support to children with hearing loss throughout Michigan. We've put together this series of webinars as a response to several parent requests for additional information on hearing loss, speech and language development, and educational issues. We hope you'll find them to be helpful, and we encourage you to share topic ideas for future discussions with us on our future evaluation that I'll send out at the conclusion of our third webinar, which will be next week, Wednesday. You'll find presentation slides located on the Handouts tab, located on the toolbar. You're able to download these or print them directly from your computer or device. There's also a questions tab. Please feel free to ask questions throughout the presentation, and we'll address them at the end of today's talk. Today's webinar is the who, what, when, and whys of speech and language evaluations. I'd like to take the opportunity to introduce our presenter today, Kelly Starr. Kelly is a speech-language pathologist and a certified auditory verbal therapist, listening and spoken language specialist at the University of Michigan's cochlear implant program. Kelly received her bachelor's degree from Michigan State University and completed her master's in speech-language pathology at Wayne State University. She has presented nationally on various topics related to pediatric hearing loss and development of listening and spoken language. Kelly enjoys being part of the U of M's Sound Support Outreach Grant, supported by the State of Michigan and the University of Michigan Department of Otolaryngology, which provides outreach and lectures to educational professionals and students in the state of Michigan. So with that, I'll go ahead and hand it over to Kelly, and we will get things started.
All right, thanks, David. I just wanted to welcome everyone to today's webinar. I'm looking out my window at this gorgeous summer day and appreciate you taking the time to listen to what we have to say. But just as David mentioned, I'm one of the speech pathologists here at U of M's Hearing Rehab Center and work with children with hearing loss. So today's topic is the who, what, when, and whys of the speech and language evaluation. I find this such a valuable topic for parents. The more information you are provided with, the better prepared we can all be to give your child the best possible care. Here are a list of some of the questions I want to sort through during the presentation. I'll be accepting questions at the end of the webinar, so please jot down any questions as they come to you so they aren't forgotten. I know plenty of times I've gone into an appointment thinking of all things I wanted to ask and left with them not answered. So I want to be sure that we have time for everyone to get their questions in. And we all know that medical appointments can be overwhelming for you and your child. If it's your child's first speech and language evaluation, there's always the added stress of finding the building, finding where to park, and dealing with unfamiliar traffic before the appointment even begins. So we want to be sure that once you're at the appointment with us, you get your questions answered and concerns addressed. These speech and language evaluations are for you and your child, and while they're a big part of our daily practice, we forget many times the terms that we use aren't words that typically are used by parents, and almost like learning a new language. My sister and I often joke that we both speak different languages in our careers. She graduated with a degree in plant pathology, molecular biology, and I graduated with speech-language pathology. So whenever we describe our daily routines to each other, we often have to stop each other and ask questions. I hope today to decode some of those new words and words we use in your child's speech and language evaluations and on the reports. Not only some of the words we use are unfamiliar to you as parents, but also the acronyms that we use. So I wanted to first go over the kind of the ABCs of speech pathology. As you notice, after our names come many letters. Without being in the field, I know it's difficult to know what they all stand for. So here's just an overview. Speech pathology is a master's level degree, so depending on where you graduated, it may be a Master of Arts and show as MA, or it might be a Master of Science, which would show as MS. The CCC stands for Certificate of Clinical Competence, which is the internationally recognized credential for speech-language pathologists through American and Speech Hearing Association, or ASHA as they call it. To earn your Cs, you have to complete your master's, a supervised clinical experience, and then pass a national exam, and also complete an internship. So to keep our Cs, we complete ongoing education in our field. SLP is the easy one to remember, and it stands for Speech Language Pathologist, or you might hear us call this speech pathologist or speech therapist, something that sets the three of us here, Jen, myself, and Ellen, apart from other speech therapists are the other letters included after our name, and that's the LSLS Cert AVT. These indicate a specialty certification for listening and spoken language and working with children with hearing loss. So we differ from our colleagues in speech pathology or other speech specialties in that we are listening and spoken language specialists that are certified auditory verbal therapists. The A.G. Bell Academy oversees the certification of professionals working with children who have hearing loss. So what it is listening and spoken language specialists, and we're defined by A.G. Bell as specialists who work with children who are deaf or hard of hearing and their families seeking a listening and spoken language outcome through the use of technology such as hearing aids and cochlear implants. Parents and caregivers are supported and empowered in their role through this approach as the child's first and most important teacher. The ultimate goal here is for the child to be successful in the general education setting. So all three speech pathologists here at U of M have this certification and work with any child with hearing loss, not just limited to children with cochlear implants. You may be thinking, my child already works with a speech pathologist at school, why do I need to come see you? And in the field of speech pathology, you're probably learning there are many specialties. For a child that has a hearing loss, we are able to look at that child's abilities compared to what they're hearing in relation to their language. We have the ability to formally test more frequently than a school speech pathologist. Also, we work closely with your child's audiologist to ensure your child has the best possible access to sound, as we are looking at your child's speech errors and language errors in relation to the specific frequencies on the audiogram, which I'll get into a little bit later. This isn't to say that the school speech pathologist isn't needed. In fact, we many times are pushing for more speech services from school, remembering that it takes a village and all professionals serve important roles to your child's success. So yes, we are all needed. Why might we refer your child to a different speech pathologist? Given our knowledge of language development in combination with hearing loss, we oftentimes see there are more than just hearing that we are working with. Just like no two children are the same. In working with children with hearing loss, we know what behaviors are due to the hearing and have concerns about behaviors that are not typically seen with hearing loss. Research has shown us that there are many times disabilities that coexist with deafness, with some studies showing up to 40% of children with cochlear implants having another disability. Some of these disabilities, additional disabilities that we see in our patients might include vision impairments, autism, difficulties with feeding or swallowing, and stuttering, just to think of a few. It's important to remember that these different disabilities require attention from and input from different professionals that specialize in those areas. When recommendations are made to see another professional, it's a great way to gain more information to best support your child's needs. So you've probably learned, excuse me, there are many educators and professionals working with your child at any at times, and probably seems like we're all doing the same things. And in the end, we're all working towards the same goals, but we might be getting there a little bit differently and might have different roles. The speech pathologist in the school or the private speech language pathologist is working on the development of listening or understanding of language. And they also may be working on speech, or how we say the sounds in our language, and the talking, or how we use the words to put sentences together. This can be done in individual sessions or group sessions. The audiologist works with the child's equipment. When in the schools, they are also likely managing the equipment of the FM systems and providing teachers with in-services on how to use them, troubleshooting the equipment. The audiologists at U of M are needed for monitoring of hearing, monitoring of the devices the child is using, and programming of those devices. Teachers for the deaf and hard of hearing, they are teachers that are specialized in working with children with hearing loss in the school setting. And I want to add that there are possibly many more people working with your child, and some might include, and not limited to, a physical therapist, occupational therapist, social worker, interpreter, language facilitator, parapro, special education teachers. So this list could go on and on, specific to what your child needs. But we understand that there's a lot of people working with your child, and that means a lot of titles, a lot of names to remember, and that we're all working together and trying to collaborate to get your child's speech and language on the right path. So who needs to come for a speech and language evaluation? The answer is any child diagnosed with a hearing loss. So this could mean a severe to profound hearing loss. Maybe it's a mild hearing loss or even a unilateral hearing loss. Also, we see children that use hearing aids, Bahas, and cochlear implants for amplification. The question of when. So prior to any speech and language evaluation, be sure to have your child's hearing tested. Generally, we like to see children that have been diagnosed with a hearing loss and fit with amplification, if appropriate. We see children as young as 3 to 6 months of age, and you're probably thinking, why so early? Even at a few months, speech and language can be assessed to determine if a child's following a normal developmental pattern. We're also wanting to see how they're going to progress over time with their amplification and make sure that they stay on track. To think about hearing is to think about brain development, and that the ears are just the doors in. Research has shown that the greatest time for neuroplasticity of brain development is birth to 3. So that development where the auditory centers of the brain is needed most is birth to 3 for a child to learn language at an appropriate rate following their peers with normal hearing. So that's another reason why we're saying earlier is better. We want to make sure that they follow a normal developmental path. After the initial evaluation, we typically recommend return evaluation or interval evaluations every 3 to 6 to 12 months. And I realize that's a wide range, but it's patient specific and based on the therapist's recommendations from the most recent evaluation. So it may be every 6 months for young children, usually under the age of 3, and then move to yearly evaluations after that. Or it may be every 6 months for children who have had a cochlear implant turned on recently. And for that population, when a child receives a cochlear implant, it's critically important to monitor the listening and language to make sure that the device is working well and programmed specifically for that child. For children that do have cochlear implants, after it's turned on, we recommend evaluations every 6 months to start. I will say that once you see the therapist, they may change the timeline based on the results of the evaluation to develop a specific plan to fit your child's needs. I can think of times that have created the need for more frequent speech and language evaluations, including A child might show a drop in hearing if there's concerns about device function, if there's been a recent change in performance on speech and language, and also the child's cause of hearing loss may increase the frequency. So what happens before the appointment? First off, call and talk with our office staff about the scheduling. Tell them you'd like a speech and language evaluation. And after the appointment has been scheduled, we want to make sure there's insurance approval. So our referral coordinator will additionally work to be sure that a referral or an order is in place for the appointment. You want to make sure that U of M has your child's most up-to-date insurance info in the system. And additionally, when scheduling, we understand that you may be trying to coordinate multiple appointments with the doctor or maybe with the audiologist. And it's always nice to group appointments together, but keep your child in mind because it may not always be best. Sometimes it can be too much for a child to have back-to-back appointments, which sometimes ends in rescheduling them. Our speech evaluations can last up to 2 hours, and by the end of which most children are fatigued. So some find it nice to take a break for an hour at lunchtime as an option before returning for a second appointment. These are just things to think about to make the most out of your appointments here. Also, you may find that we are scheduling farther out than you would like. We do have a running wait list for speech and language evaluations, which you can ask to be placed on. And then our front office staff will call as we get cancellations. So what's needed at the appointment? Be sure to bring all of your equipment, hearing devices, including cochlear implants, processors, and hearing aids. If your child's had a recent audiogram, that's great information to share. Also, any medical records or documents, including information about your child's vision. These are things that are helpful in formulating the best recommendations to fit your child. Bring along your child's IEP or individualized education plan if you have questions or concerns regarding that. Going along with that, we want to get updated educational placement information, including the people working with your child at school. Helps gain a big picture for your child's supports and allows for us to make appropriate recommendations. And lastly, bring along your questions and concerns to be sure that they are addressed. Every new child brings on its own set of challenges. While there are similarities, there are no two children that are the same. So prior to your arrival, we have likely reviewed your child's medical chart. This provides us with a little case history on what tests to select for the evaluation. The goal of the evaluation is to determine if the child has access to speech needed for ongoing development of listening and spoken language. If it's your child's initial evaluation, it allows for a benchmark to compare future evaluations and track progress. This gives a picture of their current language level and current hearing, and we make sure to use a variety of tests, including language, speech or articulation, vocabulary, and literacy based on the age of the child. Prior to starting the eval, it's important to verify that the child's amplification is working properly. So the speech pathologist will do a visual inspection of equipment and may do a listening check in addition. It's a good time during that listening check to talk about how the child is doing with the devices and hear if there are concerns about the device function. If the cochlear implant processors or hearing aids are not being utilized during all waking hours, it's a time for discussion about the child's daily routine to help understand why they might not be wearing the devices consistently. And also we want to get updated medical history and developmental history and discuss current school placement. Once in the evaluation, we want to set up the child for success. To do that, be sure to bring along all devices for hearing. Also, if the child uses glasses, be sure to bring those. I know coming in for a speech evaluation may throw off the typical daily routine, so sometimes these things can be forgotten. Keep the gum for later. So it's fine to have a drink or water with you in the evaluation, but many tasks that we're doing is asking them for verbal responses and want to remove eating and chewing for older children. If your child's a little one, it's fine to bring snacks. We will be working and asking with you for many of the questions about your child, and we understand that snacks may be a helpful way to keep your child engaged for a longer period of time. Depending on your child, you may be in the session as an observer, or you can wait in the waiting room during the testing portion. This again depends on each child and the age of the child. We always have the parents present for the review portion of the results, to go over the results, and also for the discussion of recommendations. Some of the reasons a child might come back on their own include there may be siblings with the parent that need to stay in the waiting room to reduce distractions, or some children frequently look to their parents or won't talk, are shy, and I think sometimes are less shy if the parent is not in the room. They can't look to the parent for the parent to answer for them. And we just want to set it up for the child to get the best possible score on the testing. Parents, if you are in the evaluation, you may find yourself biting your tongue during the assessment when your child misses certain items. We as the speech pathologist may not be able to provide repetitions given the test instructions, which is all part of the assessment process, so it's completely normal. It's also important to know that we don't want to teach the test. We don't want to teach just the specific words that are missed on the test, as that would skew the results over time especially. And I find this important to be sure and stop us during the results discussion, because many times we use these words and terms on a day-to-day without realizing how quickly we are talking and how often we are using new words that we haven't explained. I wanted to highlight the audiogram just as a review. So at the top, going from left to right, we have low frequency up to high frequency, like a piano keyboard. And then on the going from top to bottom, it goes from quiet to loud. So what's nice about this one here, you see in the middle a banana-shaped looking figure, and that is what we call the speech banana. And the speech banana holds all the sounds of spoken language for English. And that's really what us as speech pathologists are after, to make sure you have access to all of those sounds. Down here at the bottom, you will see the X's across, and those represent the left ear, and that would be without any amplification. So that would be without a hearing aid or an implant. Then you see HA, that would be with a hearing aid. And then you see CI, which shows if they have a cochlear implant. So again, we would want a child to have access to all the sounds in the speech banana using amplification, either a hearing aid or a cochlear implant. Without having the audiologist in our appointments, we want to be sure that they have access to all the frequencies of speech, and one way we do that is through a daily, or before the assessment, a Ling-6 sound test. And what this is we are checking to see if they have access to all the frequencies of speech by looking for a reaction for ah, e, oo, sh, s, and m. These are spread across the speech banana on the audiogram. So for a new listener, we're looking for a behavioral response to each sound, or for them to look at us. And for a more advanced listener, we're looking for them to imitate the sound after we say this through listening. When we achieve imitation, we know that they not only can detect the sound, but it's loud enough to understand the sound. So detection might be like if the TV's on in our house, but it's not loud enough for me to understand what's being said, that would be detection. But if the volume's up loud enough for me to understand, that would be it would allow for comprehension, and that's what we're after. So why so many tests? We're looking at audition or what they are hearing. Just like one way that we might do that is, again, through the Ling-6 sound check. We're looking at speech, and speech is typically thought of with the speech therapist, which includes articulation or how we say the sounds. Speech can also mean how we use our voice or our voice quality. We also test language. Language includes how we understand what is said to us or our receptive language. This would mean understanding the rules of grammar of our language. It might mean showing the understanding of following directions that I say to the child. We then test a child, how a child uses language or our expressive language, which is our ability to put words together to be understood by others. So how is the child talking? What are they saying? And how are they putting the words together? We also then want to test vocabulary. And vocabulary, the same thing. We're looking at, are they words they are understanding? That would be receptive vocabulary, and words they are saying, or expressive vocabulary. This might be done, the understanding test might be a picture pointing task, or the expressive task may be having them name pictures. Also, we look at reading comprehension as part of our test battery. So with babies, we might use a combination of norm-referenced or criterion-referenced test, which is more about informal observations. So with a young group, we may rely on you as the parent for input about what your child does at home. We also gain information through watching your child and playing with your child during the assessment. At young ages, we're assessing language, but we're also making observations about the child's play skills and their social interactions or their behaviors. For older children, we're doing more formal testing where there is a test booklet or maybe using the iPad and asking them to point to pictures or participate in naming pictures or describing pictures. Formal tests are used because they allow us to compare to other children the same age with typical hearing abilities. I want to mention that there are numerous tests and options available to use during the speech and language eval, and they'll be selected based on your child's need. So what do the scores show us? Consistently, we are using standardized tests, which are tests that are administered or given in a set manner for all test takers. So this is another reason why, based on the test, we may not be allowed to provide repetitions to your child or prompting for them to give a response. I know this is difficult for parents. As you find yourself, you might see a child miss an item you know that they understand. And this is something to remember and discuss with the speech pathologist after the testing has been completed. So it can be noted in the evaluation and lead to a discussion of maybe why did they miss that item? Was it due to the length of the direction? Possibly was your child fatigued, or maybe was it a combination of the words that were used in the direction? Raw scores. Raw scores give us the number of correct items. Each year we want to be sure that this number goes up, that they're progressing and gaining new skills. We take that raw score and convert it into the standard score. Standard scores are commonly used for tests to provide the comparison to other children that are the same age. And standard scores are plotted along this bell curve that you see here, with 100 being the average score. So moving 15 points each way gives us the normal range of abilities from 85 to 115, which are highlighted in green. This also gives us a descriptor, and the descriptions provided in the evaluation report describes a child's performance compared to children the same age. So this may read something like average range, mildly delayed, moderately delayed, above average range, severely delayed, or profoundly delayed. We've got percentile ranks, which compares a student's standard score to another child his or her age. If a child has a percentile ranking of 80, it would tell us that 80% of the students who took the same test received the same or lower score. Under the chart, you see a little box, a gray box, which might look familiar if you've received one of our reports in the past. And this box is on all of our reports and just gives a quick overview of what each one of those shows us. I'm a visual person, and when I came across this chart, it really helped create a visual for me to better understand the standard score. It again shows the bell curve on which standard score is plotted, and we see the 100 is the average for the child's age that we're testing. And you can see that's where most of the children would fall at any given age. If the descriptor is something that might read mildly delayed or moderately delayed, this might lead to a discussion about a recommendation for therapy and more support services. We also have different ages that we discuss and show. We have the child's chronological age, which tells us how old your child is. Then we have the language age, which provides us with an approximation of age given the child's performance on a test. Another way this term is said is language age equivalent, which we also list on our reports. And then there's also the hearing age to consider. So here's a chart you'll find at the top of our reports. This child has 2 cochlear implants. It lists the internal device, which was Freedom, and then the processors, which were N6. And then it lists the dates, the surgery, and the activation. If it was a child with a hearing aid, it would also say the date they were fit with a hearing aid. So let's just say the child had a profound hearing loss before receiving cochlear implants. So I look at the dates of activation, or the dates the cochlear implants were turned on, to determine the hearing age. So for this child, it would tell us that the right ear has a hearing age of 2 years, 9 months, and the left ear has a hearing age of 1 year, 11 months. It's just a good reminder that keep in mind the length of time they've had access to sound. This is an example from our reports, and it just shows that we also add in, if appropriate, the previous scores so we can track progress over time. And here you see this was a language test that shows the raw score, standard score, age equivalent, and description. I want to add that even if a child is in the normal range, it is essential for them to continue to come back for evaluations to make sure they stay there. We know at any given point that something may change, and this might not always stay within the normal range. Grade levels get harder and content gets harder. If we don't have baselines for comparison, it's really difficult to know the reasons why the progress might not be where we expect it. Overall, we're looking to close that gap between the language age and the chronological age. So here we have from 0 to 35, it's supposed to be months, age in months, and then we have scores at pre-op. So blue shows us their language understanding, the orange shows us their language expression, or how they say the language, and then the gray shows us their chronological age. So here we see a big gap between their language understanding and use and between their chronological age. Now after 6 months of device use, we see those gaps getting smaller, and then after a year and a half, we see that they have closed the gap. So what does it all provide? You'll not leave with the report in your hands, but we are able to tell you your child's current speech and language levels. We'll go over some school recommendations and also areas to target at home with your child. You as parents are the primary models for language development, and we hope to give you some goals and strategies to help facilitate that development if there are delays. I'm sure you've heard the term HIPAA floating around there from past medical appointments, and HIPAA stands for Health Insurance Portability and Accountability Act, which is a privacy rule to protect patients and his or her health information. And what it means to us is your child's speech and language evaluation and medical documents are private and not to be shared unless consent has been given. So if you want us to share reports with schools, please let us know during your child's evaluation so we can have you sign a release to share those documents. Even if you have signed a release to communicate with the school and share with your school, the child's school, it doesn't mean automatically evaluations will be sent to them. They can call and request them, but again, let us know if there is somebody that you want to receive a report so that we can talk about that and appropriately route that while you're at our appointment. I just want to take a second to say a few common recommendations for children with hearing loss. And it's ironic to think that the child's learning environment, if it's a general education classroom, may be one of the most acoustically noisy environments for them. Students with hearing loss are working harder than their peers to get into the normal range with their spoken language, and they're working harder to stay there. So if we don't access their bubble or what they're able to hear, we might as well be talking to the walls. We need to give them access, and a lot of times that might include FM. So we can be sure that we get a clear signal to the brain. New listeners may require more repetitions to retain the message in its entirety. Children's auditory systems are not fully developed until late teens. So we know as adults with developed auditory systems, we may be able to fill in the blanks of lost information, especially one, but if it's a child with a hearing loss, they might not be able to do so. So repetitions are essential, and talking to the teacher to help them understand why they are so important. We want to make sure that to maximize the auditory signal by placement and preferential seating. Also remind educators to sit on the side by the child, not across the table from them, so that their voice is closer to the child's microphones. Think about desk placement. Keep them away from open doors or windows. During assemblies, making sure that your child's at the front for better acoustics, and also to help with lip reading and visual access. I also want to say that vocabulary frequently is a topic that we bring up for recommendations, and pre-teaching of vocabulary may be needed for a child. Many children with hearing loss, if they hear in a noisy environment, they may mishear the word. And then if they mishear the word, they're not going to comprehend the meaning. So for older children, we may provide written visuals of new words for the child to see the correct spelling to assist with the accurate production of the word. For younger children, have the teacher provide a list of words to you to review the week prior to the introduction in the classroom. This will allow your child to feel confident, as they can spend more energy on learning than listening. Prepare your child for the classroom by reviewing these accommodations with them. These are skills that they'll continue to value and develop throughout their lifetime. So depending on their age, they'll need to be aware of their equipment needs. For younger children, making sure they can say if the devices are working. For an older child or a more advanced listener, knowing how to troubleshoot the equipment when there's a breakdown. So examples might be changing batteries or adjusting volume. And these are things to be reviewed at home so that they feel comfortable with the equipment and how to name and label the parts of the equipment to the teachers as required. Another important skill is practicing what to do when information's been missed. So we don't want them sitting there if they didn't understand the teacher's instruction. We want to practice at home role play these different situations so that they feel confident in being able to ask their teacher for a repetition or a classmate for clarification. Have your child practice describing their hearing loss to others, again depending on their age, so that they're confident in doing so when they're asked about it in the classroom. We want to prepare the classmates. You might want to have the teacher review how we hear, review what hearing aids are. We find this to be a really fun and positive experience for children in the class. So what's next for children? We might have recommendations for therapy given after their assessments or their speech and language evaluations. We might have recommendations for them to return for follow-up evaluations, and we want to make sure that those are scheduled before you leave, or at least so you know who to contact to get them scheduled. Also, be sure to make sure you're scheduled with audiology as it's been recommended. I also, at this point, we sometimes during our recommendations discuss sound support, which is our grant that provides this outreach across the state of Michigan. We also do school visits, so that is any one of us that is on the hearing rehabilitation team, and it could be an audiologist or a speech pathologist. And what that might be is many times it's a classroom visit. It might be observing your child in a classroom to assist in recommendations, or meeting with all the team members after a speech and language eval to review the results. It might be just a one-on-one meeting with the school speech language pathologist. It's all tailored to what your child might need. How this happens is a request is made during the appointment. You can tell us if you would like a school visit scheduled, and then we go out for any child with hearing loss. It doesn't have to be a U of M patient. Other things that sound support does beyond the school visits and webinars include training and mentoring of other professionals in the state in services and lectures. There might be roundtable discussions. We also do events where we can get families together and parents can meet other parents of children with hearing loss. Those are some of the fun things that we get together to do. I hope I've answered more questions than I've created, but now I would like to see if any of you have questions for me.
All right, thanks, Kelly. Yeah, we'll give you guys a couple minutes if you want to type in your questions. Feel free. There is a questions pane located on the GoToWebinar toolbar. So go ahead and type in your questions. We'll give you guys a few minutes. I just want to do a small recap here. We just want to remind you that the post-course evaluation will be sent out at the conclusion of our three-part webinar series. So next week, August 17th, next Wednesday, will be our final part of our series. So we just ask with the course evaluations that you take a few moments to provide us with good feedback and suggestions, which can include future topics, format, time of day, etc. Anything helps as we go forward with these parent webinars. So as I mentioned, our next and final of our parent webinar series will be next Wednesday, August 17th at 9 o'clock in the morning. So go ahead and grab your early morning coffee and log in with us. The topic will be tips and resources for navigating the educational system. This will be presented by Dr. Anita Vereb, who is an audiologist here at the University of Michigan Hearing Rehab Center. So we'll wait here about another 30 seconds here. We'll wait to see if any questions pop up, but we'll close things out if nothing comes in. But we'll give you folks another 30 seconds or so. All right, so I don't see any questions popping up, so we just want to thank Kelly for taking the time to present today, and for those of you logging on, again, be on the lookout for our post-course evaluation, which will be sent out at the conclusion of our three-part series, and we look forward to continuing our series next week. Again, that's Wednesday, August 17th at 9 o'clock in the morning. So with that, we'll conclude today's webinar. Thanks again for logging in. Have a great day, everyone.